Hey, good morning, everyone. Welcome to or welcome back to Research Showcase 2021. My name is Elan Pollock, and I'm the Director of Research for the Saskatchewan Health Authority. And I am very pleased to be moderating this morning's session on clinical and health services research in the province. We have three amazing presentations lined up, so I don't really want to delay too long because it's going to be quite quick. Each presenter will have 12 minutes to present their research, followed up by 5 minutes for questions and answers. Just on a quick housekeeping note, however, please use the chat feature on the right side of your screen to submit questions and engage with other attendees. If you were like me and in the first session could not actually find the chat function, if you go to your web browser and click on the three dots in your in the right corner and zoom lower from 100% down to 70 to 80% of the screen, the chat bar should be visible on your screen. So without further delay, it is my absolute pleasure to introduce our first presenter, Dr. Harminder Guliani, who will be presenting her research on the cost effectiveness of transdiagnostic internet-delivered cognitive behavioral therapy. Dr. Guliani is an associate professor of economics at the University of Regina. Her interests include health economics, development economics, and applied microeconomics, focusing on socioeconomic determinants of health, health equity, and healthcare financing delivery. So welcome, Dr. Guliani, over to you.
Thank you, Dr. Pollock, for the introduction. I hope everybody can see my screen.
It looks great, Harminder. Thank you.
Okay, so today I'll be presenting on the cost effectiveness of transdiagnostic internet-delivered cognitive behavioral therapy, evidence from a randomized controlled trial. This is a joint work with Dr. Julia Witt from Manitoba and Vanessa, Marcy, Andrew, and Dr. Heather from the University of Regina, along with collaborators from Australia, Dr. Titov and Dr. Deer. I'll start with explaining the motivation behind the study. As you probably all know, common mental health concerns such as anxiety and depression are two leading causes of disability worldwide and are also associated with a very high personal and societal cost. The high cost associated with anxiety and depression highlight the need for cost-effectiveness treatments so as to mitigate the economic burden of these mental health concerns. There's extensive evidence for using internet-delivered cognitive behavior therapy, or in short, ICBT, as an effective way to treat anxiety and depression. ICBT can overcome several of the barriers that patients may face when seeking face-to-face CBT. For instance, stigma, rural location, time constraints, mobility, and preference for a self-managing symptoms. When used in a routine care setting, ICBT also potentially reduces healthcare costs in terms of decreased therapist time and its ability to offer services to a large number of patients than in a traditional face-to-face CBT. But the question is the standard ICBT approach effective? Can we do better? There's still room for improvement to ensure that the services align with patient preferences, which may increase patient satisfaction, self-management of symptoms, and so forth. In previous trials of ICBT, patients have expressed a desire for more personalized treatment options, such as more frequent therapist contact. For example, standard weekly therapist contact may be increased to twice weekly therapist contact, or may be offered additional on-demand contact services. Therefore, this research evaluates the cost effectiveness of ICBT based on how it is delivered and who delivers it for the case of Saskatchewan. For the purpose of this study, patients were recruited from the Online Therapy Unit, which is a government-funded specialized ICBT clinic that offers free ICBT to residents of Saskatchewan. All accepted patients were offered the Wellbeing course, which is an 8-week transdiagnostic ICBT course developed by the eCenter Clinic at Macquarie University in Sydney, Australia. The course consists of 5 lessons that cover standard components of CBT, including the cognitive behavior model, identifying and managing symptoms, relapse prevention, and so forth. How was this course delivered and who delivered it? We consider 3 variations of the intervention. First, once weekly support encouraged patients to send messages to their therapist throughout the week. Therapists would respond each week on a set day, example, every Tuesday. for the 8-week treatment period. In the second option, once weekly plus 1 business day support offered patients the once weekly support and an additional feature where they could receive additional responses from their therapist within 1 business day of them sending a message. In other words, additional therapist contacts in this approach were only provided if the patient initiated contact. While the first 2 options were delivered by therapists in a specialized clinic, we explored another variation of this intervention known as 1WC, in which the same ICBT was delivered through community clinic groups. So just to sum up 3 variations of the intervention, which I will be referring from here onwards: 1WS, 1WBDS, and 1WC. Having said that, this study had 2 primary aims: to compare the cost effectiveness of ICBT when delivered with once weekly support compared to once weekly supplemented with 1 business day support, and that is offered by the specialized ICBT therapist. And secondly, to compare the cost effectiveness of ICBT when offered with 1W support by therapists in a community clinic who primarily offer face-to-face services versus once-week support offered by therapists in a specialized ICBT clinic. The answer to the second question may help decision makers determine the scalability of delivering ICBT. To our knowledge, no previous studies in Saskatchewan have examined the cost effectiveness of ICBT when varying the amount of support offered to patients or when the therapist specializes in ICBT. Here's some information on the data source. Patients who applied for ICBT through the online therapy unit between October 2017 and September 2018 were included in the cost effectiveness analysis. The inclusion criteria includes that patient had to be at least 18 years of age, be residents of Saskatchewan, exhibit symptoms of anxiety or depression, reliable access to computer and internet, and provide a physician as an emergency contact. We excluded patients if they had a high suicide risk or had a high suicide attempt or were hospitalized for mental health reasons in the past year or had other alcohol or drug problems. Patients who were accepted into the trial were randomized into the 3 interventions that I just explained. The analysis was performed from a societal perspective, and therefore we included both direct medical and indirect costs resulting from productivity losses. We used the Trimble questionnaire for cost associated with psychiatric illness. It is a self-report questionnaire designed to assess direct and indirect costs associated with mental health and has been utilized in the previous ICBT research. The questionnaire had 3 parts. Part 1 assessed patient utilization of various healthcare services and their frequencies in the past 3 months, such as utilization of general physician services, psychologists, psychiatrists, medical specialists, occupational therapists. Part 2 of the questionnaire collects information on the respondent workplace absenteeism or reduction in productivity in paid or unpaid work due to mental health illness in the past month. I won't go into the details of the sources of collecting per unit cost because of time constraint I have, but generally speaking, it was collected from the Saskatchewan Medical Association report, Professional Association's website, and Statistic Canada data, and I can answer specific questions on cost during the Q&A session. We also included treatment per person capital and other overhead expenses, which are directly related to the intervention, such as the cost for developing and hosting the intervention. The treatment cost per intervention was also included in our analysis. For outcome measures, we used the quality adjusted life years to measure health effectiveness over 12 months. Specifically, a patient health status was measured through a self-reported EQ 5D5L questionnaire, which is a famous one developed by the Eurocall group, and provide respondent with a descriptive system to classify their health status based on the 5 dimensions: mobility, self-care, usual activities, pain, discomfort, and anxiety or depression. Each dimension is rated on 5 levels from no problems to extreme problems. We calculated quality by multiplying the Canadian standardized utility scores with the length of the time spent in that health state. How we analyze the data, we used TreeAge Pro Healthcare 2020 software and an intention to treat approach. Specifically, I used decision analysis modeling with a decision tree that evaluates the cost and effectiveness of different strategies relative to each other. And here's this example of tree, how we model it in our study. There are 3 treatment options emerging from the initial decision mode, as you could see, 1WS, 1W, 1BD, and as well as 1C. Each treatment option, the first chance nod relates to whether or not a patient progressed from baseline to 12 weeks, and then the pathways are built through a series of branches representing particular events at 3 different time frames: baseline to 12 week, 12 week to 24 week, and then 24 week to 52 week, because that's where the cost and outcome data were collected. all pathways were terminated at the 52-week follow-up period. The probabilities, cost, and qualities of success or not success were determined from the data that we have and were added to the respective branches. We use incremental cost effectiveness ratio, which is the ratio of differences in mean cost and mean number of effects, or in other words, QALY, to analyze our results. And here are the results of our base cost effectiveness analysis. As you could see, the cost effectiveness ratio, which is the mean cost over mean effectiveness, which is QALYs, range from Canadian roughly $3,000 for the 1WC intervention to Canadian roughly $3,528 per QALY for the IWS group. Our model suggests that 1WS is the best strategy since the incremental cost effectiveness, as you could see per QALY here, is below the $50,000 threshold. In other words, 1WB or 1 business day additional intervention is dominated by all other strategies. Okay. Now the question is how effective these results are, or what if we change our cost? What if we change our QALY's value? What happens to these results? In order to understand that, we investigate how sensitive the ICR, or incremental cost effectiveness ratio, would be to changes of cost and QALYs within a reasonable uncertainty range. Specifically, the mean cost differences and the mean outcome differences assessed using the Monte Carlo simulation, and the cost and effectiveness of data were repeatedly modeled for 10,000 iterations for both cost as well as the effect. For example, in the one-way sensitivity analysis, what we did, we increased the average direct and indirect medical costs to $1,000, for example. We varied the QALYs and probabilities from a low value, which is 0, to a very high value, which is 1. In other words, the worst and the perfect health state, to determine which variables had thresholds at which our order of cost or effectiveness among change. And I'm going to use the next couple of slides to explain those sensitivity analysis results in the form of the tornado diagram, cost effectiveness plane, as well as the cost effectiveness accepted. So for example, this slide shows the results of the probabilistic sensitivity analysis using a cost effectiveness plane, which shows roughly 10,000 simulated ICR samples. As the first figure in this slide, figure A, which I would call, that compares 1WS with 1W1 business day, in which a majority of the simulated ICRs actually lies in the 4th quadrant, which is the southeast quadrant of the plane, given a willingness to pay of $50,000. What it means that 1WS generates better health outcomes for lower cost 30% of the time in this simulated sample, indicating as I said, indicating that 1WS is a better fit or better intervention. So roughly 25% of the time we found that. Similarly, when you're looking at the distribution of the ICRs, comparing 1WS with 1WC in this figure 2B, it shows that majority of the simulated ICRs are located in the southeast quadrant. So what I can say overall from these two simulations, that 1WS in comparison to 1WC and 1W1BD actually more frequently generates larger improvements in QALYs at a relatively lower societal cost. Similarly, this figure displays the acceptability curve, which plots the probability that each intervention is the most cost-effective for a range of willingness to pay thresholds. And the results suggest that the 1WS group has a higher probability for cost effectiveness, roughly at 38%, than the other two interventions, when the willingness to pay is roughly when you're measuring willingness to pay at $50,000 per QALYs. Okay. We also use the one-way sensitivity analysis, and the results are presented in the form of the tornado diagram, which shows how variations in cost, probabilities, and QALYs affect the model outcome one at a time. So there are two color bars here. The blue bar section represents how the parameter range from the low uncertainty value to the base case, while the red bar section represents the parameter range from the base case to the high uncertainty value. So variables are, in other words, sorted in descending order. The longer the bar indicates more effective parameters. So what we found is that the ICR between 1WS and 1W1BD group was most sensitive to the probabilities of improvement from baseline to 12 weeks for the 1BD group. In other words, what it means that the ICR increases as the probability increases, Whereas for the second variable, which you can see the blue bar switches to the right, indicating that the ICR decreases as the direct cost at 52 weeks increases for the IBD group. We found similar analysis for the by comparing the 1WS with the 1WC group. And the parameter which was most sensitive was the probabilities of improvement from baseline to 12 weeks for the 1WC group. Okay. So to conclude, our results provide two important policy implications for decision makers. First, adding one business day support to once weekly support is less cost effective than once weekly alone over a 52-week follow-up period. And this finding is consistent with the previous results from this trial that found that there is no benefit to offering one additional business day contact in terms of symptom improvement. And one business day contact is actually associated with greater therapist time per patient. So from patient perspective, it may have been too much care. Secondly, having therapists specialize in ICBT is more cost effective than having community clinicians who deliver both face-to-face therapy and ICBT, which may indicate that the default strategy in health to implement services through a hybrid service model where we have therapists treating both face-to-face and ICBT does not result in a program being more cost effective. Thank you for your time. That was probably too much to go through in a short time, but I would like to now hand over to Ellen, and if there are any questions, I'll be happy to address.
Thank you, Dr. Guliani. Just a reminder quickly, we do only have a few minutes here. Please type them into the chat room. I will just sort of say thank you for this work. I think the effectiveness of the internet-based cognitive behavioral therapy has been well established, and the University of Regina team has certainly, been leaders in this work. But a personal reflection is that there's not so much in health services research in the province that really looks at the cost effectiveness of it. I'm going to ask a question to you. It's more theoretical. There are some that argue that if a treatment is effective, it will be cost effective as well, that they're not separate, that you can't have a treatment that works really well and it not be cost effective. What are your thoughts on that, Dr. Guliani?
That's a very good question. And in fact, we first look at the clinical effectiveness before we jump into the cost effectiveness of it. But I think this sometimes on the surface, it looks like treatment is not effective because we are just looking at the therapist's time, but patient might be going to hospitals or going to the physicians more often, and there the cost could be reflected, right? So which could tell you that maybe on clinical part of the story, it is effective, but it is also adding a lot more cost on the healthcare perspective. So cost effectiveness actually analysis further corroborate, I would say, that definitely additional support might not be not only clinically ineffective, but also cost ineffective.
Thank you. Any other questions from the chat room? We are running a wee bit behind here. If you didn't get a chance to connect with Dr. Guliani, remember that she is in the function. You can message her privately and connect for future research. So, Shania, do you see anything in the chat? I've been having problems with my chat room, so Dr. Guliani, bear with us. But Shania, do you see anything? And if not, then
hi, Ilan. No, I don't see any other chat
okay.
questions submitted. So we do
Good.
encourage everyone to submit it throughout the presentations as well.
Just lots of positive endorsements there, Dr. Guliani, about the research that you've done. A very nice design. Congratulations, and thank you for joining us today.
Thank you for letting me present.
All right. So we're going to move on next to our second presentation in the clinical and health services research oral presentation session at Research Showcase. Our presenter is Dr. Eric Tsai. He is an intensivist and researcher based in Regina. His research interests include transitions in care from critical illness to recovery and acute respiratory distress syndrome management strategies. So he will be speaking today about discharging patients directly to home from the ICU and patient outcomes. It's a retrospective cohort study that he led here in Regina. So just a quick reminder though, please continue to enter your questions into the chat room. We're going to turn it over to Dr. Tsai. Welcome.
Thanks, Dr. Brock. I just realized I was muted there for a second. So thanks, everyone, for your attention. I'm presenting today on behalf of our research group, discharging patients directly home from the ICU and patient outcomes. Our team who helped do this project includes Chirag Gupta, Zanera Shahab, Nathan Fortan, Sandy Cassier, Jonathan Mailman, and Vincent Lau. Just some disclosures that I'll mention related to this particular project. I am a recipient of a College of Medicine Research Award grant to study this particular topic, as well as a Saskatchewan Health Research Foundation establishment grant as well. But the funders did not have any influence in the design, conduct, or reporting of this study. To give some background on my topic, in Canada, there's an increasing number of patients who are directly discharged home from the ICU. Traditionally, ICU survivors would have spent some time in a hospital ward before they would be discharged home. Their family physicians would arrange their follow-up from there. Nowadays, about 10 to 23% of ICU survivors are actually directly discharged home from our ICUs. Some of the reasons related to that include increasing demands on beds to the hospital, lots of patients being admitted with single system problems, and capacity strain. Certainly, the COVID pandemic has also influenced this as well. The current literature would suggest that there's no significant difference in return to the emergency department hospital readmissions and or mortality for these patients, at least within 30 days, but longer outcomes are relatively unknown. In Saskatchewan, we have a very large rural population. About more than 30% of our patients come from rural areas. As you can see in the graph there, Regina, for example, has a very large catchment area of over 500,000 square kilometers for patients that might be arriving from different areas. Many patients don't have family physicians, and many people report waiting to see physicians or specialists, even almost 2 months to see a specialist. These problems aren't just unique to Saskatchewan. About 20% of Canadians live in rural communities, and so these problems are throughout the country. The objective of our study was to evaluate the effect of direct discharge home from the ICU on short and long-term patient outcomes in the Saskatchewan context and compare that to patients that were transferred to the ward. How we conducted this study, so we did a retrospective observation cohort study at Regina General Hospital in our ICUs between September 2016 until September 2018. We included patients that were adults, so greater than or equal to 18 years of age. Either they were directly discharged home or they were discharged to home within 72 hours of being transferred out of the ICU. We chose that particular time frame just to ensure that they were most directly comparable to the patients that were directly discharged home. We excluded patients if they had an elective admission to the ICU, either for planned postoperative elective surgery or for other reasons, and patients that were transferred to another facility after ICU discharge, or patients that were out of province residents. Only the first admission had counted. What we looked at was a variety of different measurements of patient and clinical related factors, including demographics, Charleston scores, SOFA scores, the 9 equivalent of manpower score, which is effectively a nursing manpower score, as well as hospital costs. Our primary outcome was 90-day all-cause hospital readmissions for any reason. Secondary outcomes included 30-day and 365-day all-cause hospital readmissions. We also looked at emergency department visits at 30, 90, and 365 days, and mortality at 365 days as well. We compared continuous data using either t-test or Wilcoxon rank sum testing, just depending on normality of the data, or chi-square testing for categorical data. But for the full cohort, for our primary outcome, we looked at using the Kaplan-Meier estimator to evaluate our outcomes at 365 days. And then we constructed an adjusted Cox proportional hazards model, adjusting for age, sex, SOFA scores, NEM scoring. So, just for people's reference, the SOFA score is actually a severity of illness score. So for people who aren't familiar with that particular score, NEM score, which is our manpower score that we talked about earlier, our comorbidity score, and reasons for admission. For some sensitivity analysis, we also constructed a propensity match cohort, trying to match on the propensity score, which we constructed using age, sex, ICU admission, diagnoses, Charleston score, SOFA score, NEM score on admission and discharge, and using nearest neighbor matching. The propensity score that we constructed had an overall C statistic of 0.73, so a reasonable propensity match cohort. This is just a flow diagram of some of our results that we had done. So we looked at all those hospital discharges between September 2016 to 2018. There were about 1,309 admissions. After excluding a bunch of patients, we ended up finding that there was 389 who were either discharged home directly from the ICU or discharged after spending less than 72 hours on the ward. After excluding for repeat ICU admissions or people that lived out of province or out of country, we ended up having 341 hospital discharges in the study, of which 148 were either directly discharged home and 193 that were discharged home within 72 hours. When we look at our comparators, just comparing our direct discharge cohort to the ward transfer cohort, the direct discharge cohort, there were some differences, in age. They were younger. They tended to be different in sex. Otherwise, relatively similar in where they lived, but patients in the ward transfer cohort tended to just have less family physicians. In terms of their comorbidity index scoring, where they came from and whether they were admitted to our ICU in the past, this was relatively similar between both groups. The Charleston score of these groups was relatively low at around 0 for the direct discharge cohort, meaning that they had relatively no or few comorbidities. The ward transfer cohort was 1, so again, the same. In terms of the reasons for why our patients were admitted, there were some differences. Patients in the direct discharge cohort tended to be admitted more so with a history of substance overdose. There was also more patients that were admitted with trauma as well as respiratory failure and diabetes. In the ward transfer cohort, on the other hand, patients were more likely to be admitted for other reasons or sort of miscellaneous different reasons. When we looked at just comparing the severity of illness of these patients, relatively similar between both groups, although there were differences when they left the ICU. So the patients in the ward transfer cohort had slightly higher manpower requirements than the discharge cohort. They also had understandably longer lengths of hospital stay because they did spend extra time in hospital. And likewise, their costs of hospital stay were also higher. In terms of discharge location, there were some slight differences between the two cohorts, with more patients actually being directly discharged home to actual home, whereas in the ward transfer cohort, some of these patients went home with supports or they went to long-term care. When we looked at our Kaplan-Meier curves, there were actually some noticeable differences between the patients. So as you look over time, ED visits in the direct discharge cohort was actually significantly higher in the direct discharge cohort group compared to the ward transfer cohort. Likewise, similarly, hospital readmissions were also much higher. So about 40% of patients who were readmitted to hospital at about 365 days compared to about 30%. So there were some noticeable differences between the groups. In terms of deaths, we didn't really notice any differences in deaths at 365 days compared to the two groups. This is just a table just kind of illustrating out the raw numbers between the groups, but after our adjusted Cox proportional hazards model, we did find that patients were readmitted to the hospital more often at 90 days with a hazard ratio of 2.09 roughly. And again, they had higher hospital readmissions at 365 days with a hazard ratio of about 1.54 and higher ED visits at 90 days. Deaths, again, really no difference, but there were very few events overall in both groups to make any significant conclusions. When we did our sensitivity analysis with our propensity match cohort, we had 108 patients in each group. I won't show the entire results of the propensity match analysis, but essentially we did find very similar findings with direct discharge being associated with an increased risk of 90-day hospital readmission. So what can we conclude from this study? Well, direct discharge is very prevalent in our ICUs. It represents about 11.1% of total ICU visits. Adverse outcomes were very common. By 90 days, about 40% of patients had at least one emergency department visit in the direct discharge cohort group, compared to about 30% in the hospital readmission group. 30% had a hospital readmission. You know, 29.5% or about 30% had at least one ED visit in the ward transfer group, and about 17% of those patients were readmitted. By 365 days, you know, about 56% of our patients in the direct discharge cohort group had either a ED visit, hospital readmission, or had died, compared to about 45% in the ward transfer group. So after adjustments, we did find that direct discharge was associated with an increased risk of hospital readmissions and potentially other outcomes. But the overall event rate was still very high in both groups, and this was even seen when we did our propensity match analysis. Some potential explanations: I mean, many of these patients didn't have family physicians. Many patients lived outside of Regina, and substance overdose was a very common reason for admission for many of our patients. There was some, you know, in some future directions that we can look at is, you know, potentially some targeted interventions, future studies in determining what risk factors are associated with worse outcomes. And our current team currently has plans in place to evaluate an ICU recovery clinic or a follow-up clinic. So I know I was very quick on the last little bit, but if you had any further questions, please don't hesitate to ask your questions. Thanks.
Thank you, Dr. Sai. That was a very important and timely study that was conducted. I have a question that's come in here. It is from Adam Clay, who is the research coordinator facilitator for the Department of Academic Family Medicine, University of Saskatchewan. And Adam asks, were reported cost based on the DAD resource intensity weighted?
Yeah, so that's a good question. I mean, costing is a complex thing.
Yes.
We didn't have itemized costs. So yes, the costs were estimated through the resource intensity weight, which was multiplied by the average costs of a hospital stay, and then further multiplied by the consumer price index inflation ratios. Ideally, you know, we would like to kind of cost out each particular item, but that wasn't done for this particular study.
Thank you, Dr. Sai. We also have a question for Dr. Pena Sanchez, and I can relate to this question. So what, very interesting work, he says, what are the healthcare policy implications of your research?
Yeah, that's a very good question. I think there are potentially several potential implications from this. I think one of them is recognizing that a lot of our patients have high risk of readmission and presentation, and these can be potentially quite costly. And so we need to come up with some preventative measures for these patients to prevent hospital readmissions and ED visits, and establish the appropriate safety nets or measures to smooth their transition from critical illness to recovery. I mean, that's just one of them. I think the other thing is potentially also having discharge criteria or discharge pathway in terms of trying to select appropriate patients for discharge from our hospitals as well. And then finally, in terms of trying to fund or support home care or home health services, those are just some potential policy implications from our study.
Thank you. Geez, there's lots of questions here, Dr. Sai. Like, I think you're going to have to go into the chat room. I'm just taking liberties here at what I'm going to ask, but I do like this one here. This one comes from Leanne, and she says, excellent work, Dr. Sai and team. Was there communication with the home primary healthcare teams prior to direct discharge? The current discharge directed notes must now be pulled from the system rather than pushed to the providers. Primary healthcare providers may have no knowledge of the admission, let alone the discharge. Comments, thoughts?
Yeah, so I mean, I work in the ICU, and so I know how we work, and also how my colleagues work as well. And this is actually a very new thing for us, I would have to say. And we did do a survey actually across Canada to look at whether, what is handover like between ICU providers and primary care providers. And the results of a Canadian survey that we had conducted actually was quite interesting. ICU providers in general don't communicate very well to primary care providers, and that's definitely an area that we need to improve a lot.
I think, Shania, unless you have to give me the cane, I think we have time for one more question. This is more methodological, and it comes from Shubhendu Sanjoy, and he reads, thank you, Dr. Sai and team. Oh my goodness, my screen is moving all around here. Thank you for working with the ICU survivors safely of discharging. Do you think that assessing global morbidity burden measures, example, Charleston Comorbidity Index, can help in risk stratification for long-term unfavorable outcomes? Example, ICU survivors who have a high comorbidity burden can transfer to the ward instead of being discharged home.
Yeah, I think that's a good question. In general, our ICU survivors who were discharged directly home had a very low comorbidity index. It was, in fact, the median was 0. And of the ward transfer group, it was 1. So these are patients that generally don't have very many comorbidities. I think, someone who had a comorbidity index of 3 or 4, those weren't the patients that were being directly discharged home. Yet even these patients who had very few comorbidities, like a comorbidity index of 0, were still having very high number of readmissions and ED visits. So the Charleston score, or even the Elix-Hauser score, which is another comorbidity index, may not be perfect measures of trying to capture this phenomena yet. And so, it definitely is an area that we need to do more research on.
Absolutely. All right. Well, thank you, Dr. Sai. So many questions and positive comments in the chat room. Please, I encourage everybody to try to connect. That is the goal of this event, is to inspire, connect, and celebrate. We celebrate the work that you've done, Dr. Sai, and we hope to inspire and connect people. So please, there's lots of comments in the chat room. Hopefully you can see it and move forward from there. So thank you. Virtual high five. And we're moving on to our third presenter. Thank you again.
Great, thank you. Thanks so much.
Okay, next we're moving to inequities in rural and urban healthcare utilization among individuals diagnosed with inflammatory bowel disease. This was a retrospective population-based cohort study that was conducted here in research. in Saskatchewan. I'm going to welcome the lead presenter on this study, Dr. Juan Nicolas Peña Sanchez. He is a faculty member at the Department of Community Health and Epidemiology, University of Saskatchewan. He is a physician with a European Master of Public Health and a PhD from the University of Saskatchewan. During the last decade, Dr. Peña Sanchez has been working with interdisciplinary research teams from different countries. His collaborative and interdisciplinary research program aims to study innovative healthcare approaches that address the needs of populations and to overcome the challenges of the healthcare system. Welcome, Dr. Peña Sanchez. I'm turning it over to you.
Thank you very much, Dr. Paula. Okay, so I will share my screen. Thank you very much for the opportunity to present. It's an honor for me on behalf of my co-authors to share our work entitled Inequities in Rural and Urban Healthcare Utilization among Individuals Diagnosed with Inflammatory Bowel Disease. This is the outline that I'm going to cover within the next slides. What is inflammatory bowel disease? IBD, it's a chronic, relapsing, and remitting disease that basically we observe inflammation and ulceration of the gastrointestinal tract. The two main conditions are ulcerative colitis and Crohn's disease, UC and CD respectively. Regarding the cause of IBD, we are understanding that there is a complex interplay between individuals' immune response, genetics, as well as environmental factors. Regarding the latter, urbanization, modernization, and Western diets have been associated with the development of IBD. Individuals living with IBD require lifelong interactions with the healthcare system because poorly controlled inflammation could lead to complications, negative disease outcomes like hospitalizations and surgeries, as well as a significant impact on quality of life, direct and indirect healthcare costs, loss of productivity, and other morbidities and complications. IBD is a global condition that has been reported traditionally among highly industrialized countries. However, low-income countries and middle-income countries have been reporting increasing incidence and prevalence rates. Canada has one of the highest incidence and prevalence rates worldwide. There are variations across provinces, although it's clear that there is a common thread, time trend of increasing numbers of individuals living with IBD. It's estimated by 2030, around 1% of the Canadian population will be living with a diagnosis of IBD. At the same time, it has been described that lower incidence rates among rural residents in comparison to their urban counterparts. However, individuals with IBD living in rural locations face additional challenges in accessing healthcare. This has been described among other chronic conditions. Specialized IBD care is located in urban centers, and the gold standard of care that it's related to multidisciplinary and integrated modes of care are located in urban centers. There is evidence that there are disparities in healthcare utilizations between individuals living in rural and urban settings. This study was conducted in 3 provinces, Alberta, Manitoba, and Ontario. However, there are not studies contrasting health medication claims, as well as there are no previous studies about disparities in healthcare utilization in Saskatchewan. In Saskatchewan, it's estimated that around 30% of individuals living with this condition live in rural locations, and a previous qualitative study described that there are challenges that individuals living with IBD in rural Saskatchewan face on a daily basis, and that they call patients and family advocates called for access to multidisciplinary care teams, as well as innovation in care, like virtual care delivery. In this study, we aim to contrast healthcare utilization between rural and urban residents diagnosed with inflammatory bowel disease in Saskatchewan. Specifically, we aim to contrast outpatient gastroenterology visits, colonoscopies, claims for IBD medications, IBD-specific and IBD-related hospitalizations, as well as surgeries for IBD. For this study, we conducted in this work, we conducted a retrospective population-based study between 1998 and 2017 fiscal years using the administrative health databases listed on the slide. For case ascertainment, we used a validated case definition that required multiple healthcare contacts. And subsequently, we identified incident IBD cases 18 and older. Then we classified individuals between the two main types of IBD, Crohn's disease and ulcerative colitis, based on the most frequent diagnosis. At the date of diagnosis of IBD, the first eligible contact of this case definition, we classified individuals if they were diagnosed while living in urban or rural settings based on the population size where they had their postal codes. Then we evaluated the healthcare outcomes after the date of diagnosis, both inpatient and outpatient outcomes presented on this slide. Regarding the IBD medication claims, we evaluated three specific groups of medications. 1, immune modulators, 2, biologics, and 3, 5-SA medications. In the statistical analysis, we used Cox proportional and negative binomial regression models to evaluate associations between living in rural and urban settings and each of the study outcomes that are presented on this slide. As covariables in the models, we included sex, disease type, age of diagnosis, neighborhood income quintile, and we reported hazard ratios, incidence rate ratios, and their corresponding 95 confidence intervals. I wanted to add that we completed an stratified analysis between among those diagnosed with CD and those with ulcerative colitis. All analyses were conducted in SAS in version 9.4 at a level of significance of 0.05. In total, we identified 5,173 individual IBD incident cases in Saskatchewan during the study period. The mean age of diagnosis was 42.46. A majority of these individuals were females with the diagnosis of Crohn's disease, and majority of them were living in urban locations. When comparing the study outcomes, we identified that individuals living in rural Saskatchewan had lower gastroenterology visits, fewer gastroenterology visits, and at the same time higher prescription medication claims, specifically those for 5-SA. Regarding inpatient outcomes, we identified higher IBD-specific and IBD-related hospitalizations, 1.23 and 1.2 higher risk among those living in rural Saskatchewan in comparison to urban dwellers. In the stratified analysis, we identified similar results regarding gastroenterology visits and IBD and hospitalizations, as outlined in this slide. In addition, the higher prescription medication claims for 5-SA were only significant in the Crohn's disease group, and we also identified that individuals with living in rural Saskatchewan had fewer colonoscopies in comparison to their urban counterparts. So we observed a pattern that individuals in rural Saskatchewan had fewer gastroenterology visits, more prescription medication claims, 5-SA prescription medication claims, and a higher risk of IBD-specific and related hospitalizations. Regarding the number of gastroenterology visits, we also observed that individuals living in rural Saskatchewan had a lower rate of IBD-specific and IBD-related visits with gastroenterologists. This was a pattern that was clear as well among those with UC and CD. These findings reflect rural and urban inequities in the access to IBD care. These healthcare inequities require the attention of healthcare providers, decision makers, patient advocates to support equitable management of patients living with IBD between those in rural and urban settings, as well as innovative models of care for IBD, such as virtual care and other integrated models of care. Thank you very much. I will be happy to hear your questions, but before I would like to acknowledge my fellow research team members, as well as the support of the SCPOR data service platform or funding agencies, SCPOR and SHERF. In addition, it's important to highlight that this study was used to identify the data provided by the Saskatchewan Minister of Health and eHealth, and that the interpretations and conclusions that I presented here do not represent those from the government, Minister of Health, or eHealth. Thank you very much.
Thank you, Dr. Pena Sanchez. I love that from. You know, while questions are coming in here, I really appreciate and love the way you were able to move your presentation to speak about equity and the differences you found in rural and remote. What do you think are some of the next steps that we need to do? And I'm not sure if you were able to join us for some of the earlier conversations we had about equity and truth and reconciliation. And you know, I don't want to put you on the spot there, but what do you think there from your finding? It looks clear to me that there are some real gaps here.
Thank you for your question. Definitely, we are observing here a pattern that you don't expect to see these differences between individuals living in rural and urban Saskatchewan. Obviously, these kind of services are located in urban centers. However, we need to identify those barriers that do not let individuals to access in a timely manner to the specialized care. That will be one component, to have access to specialized services in a timely manner. That will be one of the challenges. So having a diagnosis on time, and then access to the medications or the treatments or different resources to control inflammation and disease-related outcomes. At the same time, it's important. The COVID pandemic changed the way that we deliver healthcare, yes, and that it gives us space about virtual care delivery. But virtual care delivery is not for everything. There is a specific space, and we're working on studying that in a different study. And it needs to promote it, especially for those individuals that are living in rural areas. At the same time, talking about equity, there is another study that one of my students completed about inequities observed among individuals living with IBD, First Nation living with IBD in the province, and we observe similar patterns, that there are differences that you don't expect. There are no theoretical answers to say that the disease, the complexity of the disease is different between groups. Definitely for rural and urban Saskatchewan, they should be similar. And all of these evidence is telling that individuals do not have the same access to the disease, to the treatment of their diseases. Despite that, we have universal coverage, we have the resources, so that we need to evaluate integrated models of care, virtual care, as well as different approaches like patient navigation systems, working with patient advocates in the ways that we can improve delivery of care.
Yeah, no, thank you, Dr. Pena Sanchez. I'm trying to I have like very bad eyes, so I'm trying to monitor the chat room, but I'm going to probe you a little bit more about the role of patient advocates and, you know, sort of, I forget the term. I know what you mean. Sorry, I'm having a brain blank here. But you know, so how do you see this moving forward? So using, you know, more patient advocates in this area and having you know, sort of more advocates within the system to access this care. What are your thoughts on that?
Thank you very much for the question. That's a very important thought because this is a patient-oriented research. We use a patient-oriented research framework to develop this study. And patients and all of this evidence that I just summarized in a couple of minutes about other projects in the field of IBD, we are working with patient advocates and family advocates. They have the expertise of the experiences of what they are facing with they are experts of living with disease and navigating within the system. We have a different perspective as researchers or healthcare providers that can complement it in a really good way, how we can make changes that could have long-term effects. So I think that's very important to continue working on this line and defining innovation in care. We can have an idea as researchers or as healthcare providers, but patient might have a different one. And that's very important to advocate for them, to let them share their ideas.
Yeah, thank you so much, Dr. Pena Sanchez. So I'm going to wrap this session up. I want to thank everyone and all three of our presenters, Dr. Guliani, Dr. Sai, and Dr. Pena Sanchez, for those extremely exciting. I'm totally pumped by learning about the work that's going on. There will be, just as a sideline, there will be Zoom surveys or online surveys through REDCap being sent to everybody that participated in these sessions. The focus of these sessions or the follow-up survey is to provide feedback to the presenters on the research that they presented. So it's not shared publicly, but it is shared to those that have been awarded the opportunity to present their findings orally. Our next program is not until 12:30. So please take a 15-minute break here. Go grab a drink, take a stretch break, and we'll see you at the patient partner session at 12:30. And again, I wholeheartedly encourage you to connect through chat or private messaging and let us continue to grow health research in the province of Saskatchewan. Thanks, everyone. Take care, and we'll see you at 12:30.